Hi, thank you very much for having me here at the International Conference for the Development of Palliative Care in Adults and Children. My name is Doug Levine. I'm a physical therapist in the United States, and I work predominantly with Duchenne muscular dystrophy. I work in a lot of different areas, including a clinic, in a public school setting, and I also see kids at home. And I work with Cure Duchenne on providing education to families and to therapists all about best practices for Duchenne muscular dystrophy. So I'm very happy to be here today. I will be presenting on the role of physical therapy in the ambulatory stage of Duchenne muscular dystrophy. So let's get started. That's just a little bit about me. I work with kids all different ages from 0 to 21 years. And like I said, in all different settings. So hopefully I will be able to bring a different perspective or a larger perspective on treating kids with Duchenne muscular dystrophy. But the focus today will be on those in the ambulatory, excuse me, those in the ambulatory stage. So the objectives of my talk today: first of all, understanding the role of physical therapy in the ambulatory stage of Duchenne muscular dystrophy. Also understanding the progression within the ambulant stage of DMD. So within the ambulant stage, there are different stages, and we'll go over those as well. Understanding the physical therapy evaluation and the care plan process. What are we looking at when we do an evaluation? How are we determining how often we're going to see the child and what kinds of things we're going to work on? And then establishing appropriate gross motor goals. Very, very important. The focus with physical therapy with Duchenne muscular dystrophy is really very different than a lot of different diagnoses. So we'll kind of go over that, what that looks like as well. So kind of getting started, just an overview. I'm not going to spend a lot of time on the physiology and the makeup of DMD, but I think it's important to look at the primary impairments. So what muscle groups are typically affected? And you can see from the drawing here that initially we get significant weakness in the upper body and the anterior side, the pecs, the abdominals, the neck flexors, and then throughout the posterior side, the traps and the shoulder and the upper back muscles, as well as hamstrings and glutes. So that's typically where we're going to see the first amount of weakness. And then as well with as muscle stiffness. So in those muscles, as they start to get weak, as fat and scar tissue and fibrosis is laid down in those muscle groups, they're going to start moving less and getting more stiff. And so the secondary impairments, the things that we'll see from that, the consequences of those initial impairments, we'll start to see contractures in those muscles, in the heel cords, in the hip flexors, as well as the low back extensors. Kind of a lordosis is common with these kids. That's where we will initially start to see these contractures. As the weakness throughout the ambulatory stage, as the weakness continues, we'll start to see the kids implement these compensations and limitations. So they're still trying to be a kid. They're still trying to do all the things that kids do with walking and running and going upstairs and playing with their friends. But they're having, as the weakness progresses and the stiffness progresses, they're having to figure out different ways to do that. We'll start to see, and this is an important one that is not as you don't as directly see this, so it's important to look for this. Activity and tolerance. As the kids start having difficulty with things, they're just going to start shying away from those activities that are difficult. Uh, that's important to look at, because from a social perspective, from a psychosocial perspective, we want the kids to be involved in their environment with their friends, doing different things with their family. If they're going to take themselves out of the equation and be doing less, that could lead to depression and other things like that. And then also secondary impairments are balance disturbances. As they're implementing these compensations and these accommodations within their body, it's going to throw their center of gravity off in standing. It's going to kind of throw everything off. And if the progression of the disease is quicker, a lot of times it makes those balance disturbances even more difficult, because they happen so quickly and there's not a whole lot of time for their bodies to adjust. So just the clinical presentation of DMD, what kinds of things are we looking for? Toe walking is very common, because we'll start to see that weakness and the tightness in the heel cords. So that's usually one of the first things that we'll see, as well as pseudo hypertrophy of the calves. So enlargement of the gastroc and soleus muscle, sometimes in the upper body as well, sometimes in the deltoids, wrist extensors, and even the quadriceps, but that's a lot less frequent. The most common thing is the enlargement of the calf muscles. A lot of parents will think that that's due to strength. They're very strong, and so their calf muscles are very big. But in effect, it's the laying down of the fibrosis and the scar tissue, things like that, that are causing the enlargement of the calves. We'll start to see Gower's maneuver. This is usually early on, sometimes around the age of 3 or 4 or 5. We'll see Gower's maneuver, and that's just their compensation for getting up from the floor, where they use their hands to kind of walk up their thighs and get themselves to a standing position. I have a couple of videos, so we'll show videos of that in a little bit so you can see. Waddling gait, again, as the compensations are taking effect, they're having to use a lot of other movements. And so you'll see this kind of lateral shifting in the gait. And then difficulty with stairs and running. These are kind of for obvious reasons. As they're getting weak, those things demand a lot from the body, a lot of muscle activity, and so those things are going to become more difficult. So those are usually there are definitely other clinical presentations, but those are usually the first things that we'll see. So one of the, especially in the ambulatory stage, one of the most important things that we talk about is education with the family. What types of things are okay for the kids to do? What should they shy away from? How do we keep them involved and doing activities with their friends and family without causing more damage to the muscles? So just some general guidelines, some general rules. We want to try to eliminate or limit stairs or hills or running or jumping as much as possible. This is not always easy, depending upon people's living situations, what they're able to modify in terms of the house or apartment. It's also the age of the child. I've worked with kids that have been diagnosed with DMD that are 2 years old. It's extremely difficult to get a 2-year-old not to run or jump. So sometimes we just want to try to limit those activities as much as possible, or take rest breaks. Don't do repetitive muscle work to fatigue. So kind of a hallmark is with activities is we don't want to work on strengthening. So if we're doing repetitive muscle work to fatigue, whether it's walking up hills or using weights or some activity where they're getting really tired, even if we don't see it, more than likely there's damage happening to the muscle underneath the surface. And so that damage is cumulative. We want to try to avoid or limit that damage as much as possible. We want to look at the daily activity, the cumulative daily activity in all environments. And what I mean by that is not just how far are they having to walk in one time. Like if they're having to walk one time a day for a half a mile, that's actually not as bad than if they're having to walk a total amount of 4 miles or 5 miles throughout the day. So we want to look at the total amount of activity. What does that look like, and how can we adapt that so that they're not doing so much activity total in one day? Like we said before, activities which are based on strengthening are not appropriate at any age. Again, this is an education thing for the parents, because a lot of times if they know there's a diagnosis of the child at the age of 3 or 4 and they're not seeing a lot of effects from this diagnosis, they're not seeing difficulties with playing or getting up from the floor, there's a tendency of the parents to just let them do any activities that they want to do. But again, with the damage and the effects being cumulative over time, we want to try to modify these activities early on. So the PT and the OT plan and the goals are mostly in line with maintenance, maintaining strength, maintaining range of motion, and improving efficiency. So having them go places or do things without exerting as much activity. Even though, so typically with Duchenne, there is an improvement in gross motor skills until about the age of 7. So even if they're improving in gross motor skills, we want to be careful about trying to work on strengthening type activities. And then promoting participation in a modified manner that allows them to still be with their peers. So we don't want to take away activities. We don't want them to not walk. We don't want them to not play. It's really important that the kids still be kids and take into account their social well-being and what's important to them. So that's where the physical therapy is so important, is helping to navigate this kind of fine line with doing things but not doing things too much. So just going over real quick exercise, it really needs to be individualized for the patient. So one exercise, like walking slowly on a treadmill or playing in a swimming pool or doing a stationary bike, that one exercise might be important and might be helpful for one child, but same age child, that might be way more difficult for them. So it really needs to be individualized. No eccentric exercise whenever possible. Eccentric, compared to isometric or concentric, eccentric exercise recruits the most amount of muscle fibers and puts the most amount of stress on the muscles. So we just really want to try to avoid those things when possible. So those things where the muscles are activated but elongating, going downstairs, lowering themselves to the floor, lowering a heavy object, those type things are eccentric exercises. We want to be careful of those and really try to avoid those whenever possible. Incorporate frequent rest breaks into the exercise. So exercise in and of itself for kids with Duchenne is not bad. It's just the appropriate exercise, building in rest breaks. And then low load aerobic exercises are best. Swimming, bicycling, things like that. There was a study done in 2017, a really important study, and it's it's referenced a lot of times. It's called the No Use is Disuse study by Jansen et al. And basically what it talked about is that it's important to have appropriate exercise. If we end up not having these kids do any exercise or just sitting on the couches in an effort to preserve their muscles, then they're going to get disuse atrophy, decreased cardiac output. So trying to find that balance of good exercise. So looking at the different stages within the ambulatory stage of Duchenne, we have the early ambulatory stage, and that's usually from maybe 2 or 3 years old till around 5 or 6 years old. The mid-ambulatory stage, when that early ambulatory stage ends to about 8, 7, 8, 9 years old. The late ambulatory or transitioning stage, and we'll go into these stages in just a moment. And then the non-ambulatory stage. The stages are not broken down hard and fast by age, but more about function. So, how are they doing? What does walking look like? What are they able to do? So with that early ambulatory stage, this is where sometimes we don't see, clinically, we don't see the effects of it as much, but things can start to show themselves. So usually there's a delay in walking, a delay in gross motor development with most of the kids. That's been well documented. So, and usually that's kind of retrospective, looking back. Even if the parents did not get the diagnosis until 3 or 4 or 5 years of age, looking back, they will say, yeah, he didn't walk until 18 months or 20 months or something like that. So we'll see a delay in the walking and in the gross motor skills. At this age, if we're starting to see things, it's kind of subtle. They're maybe falling a little bit more or having a little bit of difficulty with balance, having a little trouble keeping up with their friends, like on a playground, throughout school. They don't have the endurance or the stamina or strength to keep up with their able-bodied peers. They're starting to show a little bit of that Gowers, so they're having a little bit of difficulty getting up from the floor. Usually the diagnosis on average is around 5 years of age. With so much awareness and improved care and testing, and how testing has gotten easier. You used to have to do a muscle biopsy. Testing has gotten easier and cheaper. And parents are more aware, pediatricians are more aware, neurologists are more aware. This mean age of diagnosis is slowly being pushed back. And then there might be, in this early ambulatory stage, you might see other global developments, including verbal or fine motor. A lot of the kids have speech delays as well, whether it's articulation or other mild speech issues that typically tend to get better over time, especially with speech therapy, if that's included. The speech delays or the verbal delays tend to minimize over time. So where does physical therapy play into this early ambulatory stage? What kinds of things are we looking at? A lot of education. This is a overwhelming diagnosis for most of the parents, and they just need direction. What to do, what not to do, what's okay, how should they modify activities? Are we starting a stretching program? I think that's really important. Even if there's not a lot of tightness, it's important to start that early, both for the parents and for the kids. There tends to be a lot more compliance if we start that stretching program early. Begin the use of night splint bracing or ankle foot orthoses. Again, really important to start earlier rather than later. I will typically start this with a lot of my kids if they've been diagnosed at 2 or 3 years old. And that's for a couple of reasons. One, I want to try to prevent them from getting tight. And the second thing is compliance, both for the child and for the parents, but more for the child. It's a lot easier to start this kind of thing at 2 or 3 years old and get compliance from the child than it is to start it at 6 or 7 when there's already tightness and they're a little bit more set in their ways. So that nighttime splinting provides a long-term stretch, maybe 7, 8, 10 hours of stretch. So it's really, really important. And I try to really stress to the families how important that is. I put introduction to swimming and cycling, but it's really those exercises or those activities that are aerobic, that are low load, There are certainly other exercises that can be built into this, but those are usually the two that come to mind first as kind of low load aerobic activities that most of the kids like. As far as cycling goes, I would, if the child likes to ride a bike, and especially if they're starting to see some balance issues, I would definitely use training wheels or a three-wheeler or something with a bicycle where they're um, not having to really focus on their balance at the same time that they're trying to have fun. And then I never think it's too early to initiate self-awareness of physical exertion. And what I mean by this is having the kids be in tune with their bodies. So when they start to feel tired, have them sit down and drink some water, have them take a break, just using different visuals or checking in with the child and seeing how they're doing so that they get in tune with their body, because as they get older and changes are happening, that's going to be really important for them to be their own self advocate and for them to know what they're feeling and to be able to verbalize and act on that. So the mid-ambulatory stage, the next stage within the ambulatory stage, we're starting to see more of the effects of the Duchenne. We're starting to see more clumsiness, more falling, more fatigue. They're having they're having more difficult time walking further distances. It's becoming more obvious that they are slower than their peers. They're not able to keep up with their friends. We're starting to see that waddling gait, and I'll show you a video of that in a second, but that's the walking with more of a lateral shift as they're walking. Much more difficulty with running and jumping. Going down the stairs is becoming a whole lot more difficult. They're usually using two hands on a handrail. They're going up or down sideways. We're starting to see more toe walking in many of the kids. And then that Gowers maneuver, or kind of walking their hands up their thighs in order to get up from the floor, that's becoming a lot more prominent. What does the intervention look like during this stage? I think it takes more of a critical eye from the therapist standpoint or from the doctor's standpoint, because more changes are happening and more changes are happening quickly. There more compensations are being used. We want to try to preserve function. We want to try to preserve symmetry and range of motion as much as possible. And I kind of feel like at this stage, that becomes more difficult, and really a lot of our care and intervention is during this stage. So you want to monitor often, check in with them, function, endurance, how are they doing keeping up, manual muscle testing, and then range of motion. I put a star by upper extremities, lower extremities, and trunk, because I think it's important. As physical therapists, a lot of times we're looking at the lower extremities, what's happening in the ankles and the hamstrings, what's happening at the knees. We're looking at a lot of those ambulatory type muscles, and if we're not careful, they could be getting tightness throughout their wrists or finger flexors, elbows. The pecs are getting tight, and if we're not keeping an eye on that, that could get to the point of a contracture. So a lot of parent and client education, that's really common throughout the different stages. We might want to try to increase the stretches at this point, or at least focus the stretches on certain ones. If their heel cords are getting, or the gastroc or soleus are getting more tight than the others, then we want to focus a little bit more time. If we're noticing some asymmetry, that the right side is tighter than the left, we want to focus a little bit more time on there. So again, that's where that critical eye is important. Continue the use of the nighttime splinting, the nighttime bracing. And then we want to start to look at, if it's available, if that's available to us, we want to start to look at the possibility for assisted mobility, whether that's a power scooter or a manual chair for long distances or a power wheelchair, something that not just can they get around, but can they get around on their own. So independence is so important. And as these children are starting to lose independence, we want to do everything that we can, not just to help them, but to help them preserve their independence. That's so important for all of us. And then school consultations. The children are, if they're going to school, they're spending a lot of time, that's 7, 8, 9 hours in the school environment. So very important to make sure that we're consulting with the school, make sure that the teachers and all those adults that are coming in contact with the kids with Duchenne, making sure that they're aware of a basic knowledge of what Duchenne is and how they progressively get weaker and what's important, what activities are important, what to avoid. So just kind of doing a basic consultation with the school, I think, is important. The next stage is the late ambulatory or transitioning stage, and that's where the weakness is really taking over. So the proportion of the healthy muscle to the muscle with fibrosis and scar tissue and fat, um, that's kind of taking over. So they're really starting to get weak at this point. Whatever compensations they were using for standing up from a chair to walking to getting up from the floor, they're just not working anymore. The muscles are just getting too weak, and it's becoming a lot more difficult for them to keep doing these things. So they require alternative means of mobility. How are they going to continue to get around? That's why I think in the mid-ambulatory stage, it's important to address the alternative means of mobility. But really at this stage, we really need to be looking at what do they need to preserve function. And also, how do we adapt or modify their activities? So if they're not able to get up from the floor, if they're having difficulty getting up from chairs, if their positioning in a chair at school does not look good, or they're really asymmetrical, we want to look at those things. How can we adapt them? Do we need to put them in a little bit higher chair so it's easier to get up to standing? Do we want to try to limit the amount of time that they're on the floor? Especially in school, if there is still some floor time that's happening, maybe they can stay in a chair so that they're not having to get up and down from the floor. We're also seeing increased tightness as the weakness and the scar tissue and fibrosis is continuing. We're starting to see more contractures kind of built in, and then difficulties with ADLs or activities of daily living are showing themselves. Bathing, dressing, as the upper extremities are getting weaker, and if they can't lift their hands up over their head, washing their hair, bathing, brushing their teeth is becoming more difficult, as well as, and I think this is where occupational therapy is so important as well. As they're losing these abilities in the lower extremities, they're also more than likely losing a lot of these abilities in the upper extremities. So what is feeding? What does hand to mouth look like? What is being able to get a cup from the table to their mouth look like? So we want to make sure that all those things are addressed. And so the intervention, I just kind of talked a little bit about it, but we want to try to make sure that some sort of stretching program is in place, whether it's done by the schools or by the parents. That's really important at this stage as they're starting to walk less. Upper extremities and lower extremities are getting tighter. So we want to make sure that we're addressing those things. Use of swimming and cycling for exercise, it becomes more important as they're walking less and they're getting more sedentary and less activity and less exercise. We want to try to find those things, whether it's power wheelchair, soccer, or different activities that they can engage in, and not have to worry about the walking part of it. We really want to look at scoliosis and their respiration. What does that look like? I think that's important as therapists and as medical professionals, to look at too. With scoliosis, what is their positioning in the wheelchair, the power chair, manual chair? What does that look like? If they're really collapsed to one side, if they're not able to hold themselves up in a good sitting position and they're really kind of collapsed throughout the trunk, that's going to make breathing, digestion, circulation a whole lot more difficult. And we can teach breath stacking. It's a pretty easy thing that we can implement. It's not anything that you have to be certified. And there are, if you go onto YouTube and you look up breath stacking, there are many videos that show how to do it. And basically, as the muscles around respiration, around inspiration and expiration get weaker, the kids are not able to get as deep a breath in and out. And so there's a lot of stale air that stays in there. And so we want to make sure that we're getting good passage of air. Breath stacking is a technique where it tries to increase your inspiration as well as your expiration. Something that the kids can do anywhere, sitting, standing, sitting on the bed, anywhere. Again, if we haven't already, then we want to look at some sort of power mobility if that's available to them, whether it's a scooter or power chair, and also look at standing options. So here in the United States, we have a lot of access to standers, which is a piece of equipment that allows the kids to stand. You're kind of strapped in and supported, but they're not having to do the work of the standing themselves. But it's good to for range of motion, for bone density, for respiration, for circulation. There, it allows them to be in a standing position, and they can do different activities in that standing position. And again, continuing with school consultations and starting to look at secondary schooling. Does the person, usually the adult at this point, does the adult want to go to college? What does it look like after they're done with primary school? So here's some videos that I was telling you about before. This is during the first one is during the early ambulatory stage, and it's what we call a Duchenne jog. So honestly, if you didn't know that there was any diagnosis of Duchenne, it's not extremely obvious looking at this, but what you can kind of see is increased upper extremity movement. It's a little bit different from a typical run, so he's not getting, you can see when he starts out, there's a slow start to it. He kind of has to build some momentum, and then the hips and the knees are not coming up as high, but this is really early on in the process. So the next one with the mid-ambulatory Duchenne jog, oops, you can see the effects a little bit more. So he kind of has to get more momentum to get started. And there's a lot more compensatory movements that are happening with the upper extremities. You can see his shoulders are back, his head is forward. There's not as much of a time. One of the hallmarks of running is that there's a period of time where you have single limb stance. So you can see that he's not getting his feet up as high, and he's not getting like a true running. So that's what the Duchenne jog looks like from the mid-ambulatory stage. And then the late ambulatory stage, the waddling gait, you can see it's a lot slower. It's pretty obvious with this one to see the compensations. Increased lordosis through the back. He's doing everything that he can, so he's pretty stable. His balance looks pretty good. He's pretty stable, but he's doing everything that he can to maintain that walking position and that ambulation. He's also kind of locking out the knees, so he doesn't have to use the quads as much. The feet are turning out, especially the left one, to increase the center of gravity and his balance support. Arms are out to the side, but you can kind of see there's more, he's getting more lateral trunk movement. It's not extremely obvious, but he's kind of shifting from left to right in order to try to advance those legs. So just some things where you can see what that looks like. And then the Gowers, this is what I would term a mild Gowers. So really, this is somebody that's probably at the early ambulatory or even mid ambulatory stage. But you can see a couple of things. Again, if you didn't know anything about the Duchenne diagnosis, it might not be extremely obvious, but you can see how he gets up from the floor. He really has to rotate, puts his hands on the floor, uses both legs at the same time. So typically kids will get up with a half kneel position. With this, he has to get both feet underneath him and then push himself up. So this is more of a mild Gowers position. So when I'm working with a child for the first time, or even if I'm doing a reevaluation on the child, there are some things that I'm looking at during the evaluation process. So there's a subjective component to it, and then an objective component to it. Under subjective, I just want to get an idea of what their general health is like. Are they sick often? Are they sleeping okay? And any issues like that, are they eating okay? I just want to see if there's something that we need to refer out to um, an endocrinologist or a speech therapist for eating or feeding issues. What does the developmental history look like? This is where I'll ask them, at what age did they sit up? Did they stand? Did they walk? At what age did they run? So trying to get an idea of where we started and how that developmental history was. I want to ask them what their previous therapies were. So had they received physical therapy or occupational therapy or speech therapy before? What medications or supplements or nutrition are they on? Or are they currently involved in a trial with one of the pharmaceutical companies for Duchenne? Are they taking any supplements? And what is their general nutrition look like? A lot of the kids, especially the ones that are on steroids, tend to be kind of overweight. The steroids tend to allow the kids to gain weight. And so what does their general nutrition look like? I think that's really even more important as they're not building new muscle. If they have steroids that tend to have them gain weight, it's really important that they have a balanced diet. They're taking in enough protein. So I just want to get an idea of what the nutrition looks like. What's their safety like and tolerance of daily routine? Are they doing things that are unsafe at school or even at home? Are they playing on playgrounds if their balance is not great, or if it's really difficult? Are they at risk for falling? I want to get an idea of pain and fatigue. This is a lot of times overlooked, and it's a little bit more difficult in the younger kids for them to verbalize this, but is the child having any pain anywhere? What does the fatigue look like? Are they falling asleep as soon as they get home from school? Are they falling asleep in school? What do their sleep patterns look like? Are they sleeping throughout the night? Do we need to try to get a sleep study? Are they getting some airway obstruction where we need to address that? And then what does the educational setting look like? Are they getting school through the home? Are they going to a public school? What does that look like? What does their day look like? Again, what is their cumulative amount of walking look like? Some of the older schools are really, the campus is really spread out, which requires the kids to do a lot of walking. And especially if they're having to carry a heavy backpack, are there things that we can do to minimize that? Can we have them keep their school books in each classroom so they're not having to take around a heavy backpack? And then lastly, and this is extremely important, what are the concerns and what are the goals of the parent and the child? I can say all day long what I think the goals should be and what I think is important for this child, but it's way more important what's important to them. Because if they're not working on things, or if I'm giving them things that aren't important to them, then they're just not going to do it. So what are the concerns? What are the goals from the family perspective? And then some of the objective things I'm looking at: range of motion, manual muscle testing, grip strength or pinch dynamometry. There's been a pretty significant correlation with decline of grip strength and decline of function. So we want to look at that and what that looks like. You can get a fairly inexpensive grip dynamometer that measures the grip strength. Functional status: how much help do they need with standing, with walking, with getting up from the floor, with bathing, with feeding themselves, looking at all of those different activities of daily living and how they're doing with it. And then taking a really close eye on their walking. What does it look like? Are they showing that Duchenne jog or the waddling gait, or something that I need to step in and modify? And then looking at some of the functional tests that are pretty easy to implement: the 6-minute walk test, the NSAA, or the North Star Ambulatory Assessment, and the upper limb test. So all of these are just pretty basic tests that we can do to get a baseline. So we're not comparing them to normals, or we're not comparing them to typical developing kids, but we're looking at it over a period of time within themselves. And I think it really gives us some good objective data, especially if we're not seeing the kids except every 6 months or something like that. And then a respiratory screening. I'm not a respiratory therapist, so I'm not going to be doing all of those pulmonary function tests, but just getting an idea of, are they taking in enough air? When I ask them to take a deep breath, does it look like they're really filling up their lungs, or are they just shallow breathers? Looking at spinal scoliosis screening. So just basically, lifting up their shirt, do I see a curvature? Are they really shifted to one side? And then if there is equipment that's on board, whether it's a stander or nighttime AFOs or a wheelchair of some sort, I want to look, how is it fitting the child? How is it working for them? Is it making their lives easier? Are they having to fight the equipment, or is the equipment helping them? And then the care plan for Duchenne. So going forward, after I've done the evaluation, I want to set the frequency of the number of sessions and how often I'm going to see the child. There's lots of times, especially if early on, or if things are stable and I feel like the parents are doing stuff at home, and they have a good idea of Duchenne and what's involved with all of that. I might see these kids once a month or once every 6 weeks to check in. They don't need me to sit there and watch them do the same activities that they're doing at home. But in that regard, I don't want to go 3 months or 4 months or 6 months without seeing them, because some kids progress rapidly, and we might see a change in there that we might miss if we're seeing them every 6 months. So usually if things are stable, I might see the child every 4 to 6 weeks. If something comes up, they're having their gait has changed, they're having difficulty getting up from the floor, something has gotten more difficult, then I might see them weekly for a period of time to work on that issue. Constantly educating the parents, because this disease, the progression changes and things change with the child. So making sure that the parent has all their questions answered throughout all of this. And then what do we need to recommend to slow down the progression? Do we need to improve the seating in the wheelchair? Do we need to add swimming or cycling? What exercises are appropriate for that child to do at different stages? Do we need to recommend any new equipment? Is there something that's going to help improve their independence that they don't already have? How do we modify those daily activities, whether it's at school or home or with their friends or family? How can we keep them participating and modify those activities slightly? And then a lot of times the physical therapist or the occupational therapist, we're the ones that see the kids most frequently, or even for a long period of time. So we're developing a relationship with that family, with that child. We see that child fairly often. It's really important for us to look at the whole picture and refer to appropriate healthcare providers when it's appropriate, whether that's a psychological evaluation if we feel that the child is having some depression or issues with well-being, Is there a digestion issue? Is there, an endocrinology issue? Is there an orthopedic issue? It's good for us as the therapist to know when to make recommendations to the family, to see other healthcare providers, and then also being very clear with the family how often I'm going to see them and what I plan to do and when I plan to reassess. So I really want the family to be educated as much as possible, not just activities for them to do right then and there, but how often am I going to see the child and what's involved with physical therapy. So just a little bit on range of motion, because it's something that we're able to do for the kids. I think it's really important. It's important for us as therapists, but really for the parents to have hands-on with the kids, so they can feel how the muscles feel if there's been significant tightness in a short period of time. So when giving strategies for range of motion programs, really needs to be specific for each client. Like I said before, uh, there's going to be different asymmetries. This muscle is going to be tight for this person, but not for that person. So just like the exercises, the range of motion needs to be specific to the client. Check in with the parents often. Make sure that they're comfortable with doing the range of motion. Have them show you the range of motion, because sometimes parents might be a little bit shy or a little bit self-conscious, and they might tell you, yeah, I'm doing it, everything is going fine, because they don't want to say that they're not quite sure. So so have them do that in front of you, and then check in with them on a regular period of time to go over that. You really want to try for stretching. You want to try to stress that it's important that they do it on a daily basis. This is not really realistic for some parents. If there's other siblings, if it's a single parent, we want to try to shoot for every day, but we also need to deal with reality. So, just encourage them to do it as often as possible. And then basic guidelines: stretching should not hurt. It can be uncomfortable. You're stretching the muscle, but there shouldn't be a lot of pain associated with it. Sometimes, and this is important, to hold the stretch for 45 to 60 seconds, because sometimes we go into a stretch, we hit this wall, and then over time the muscle will relax. After maybe 10 or 20 seconds, the muscle will relax and we can get a little bit further stretch. And then observe for compensations. And what I mean by this is um, make sure that they're stretching the correct way. So what muscle that we think we're stretching is what we're actually stretching. On the Cure Duchenne website, which is cureduchenne.org, there is a tab at the top under Care. And if you click that, and if there's a tab under that that says Stretching, and there's a bunch of really good videos that my colleague Jennifer Wallace Valdez has put together for stretching. So that's something that you can refer to the families or for yourself. It shows for 6 of the most common stretches for the most common muscles that get tight with Duchenne. It shows hand placement, how to push, the position of the child, the position of yourself. Really good resource there. And then this is kind of what we talked about before. So it needs to be specific, repeat the training, and then continually look at the activity analysis and modification. So what are they doing? How do we need to modify activities? Are they doing too much? And is it causing fatigue, an amazing amount of fatigue early on throughout the day? And just a picture of what those nighttime braces look like. And the reason that I like the nighttime braces is it gives that long-term stretch. Again, it's important that we have our hands on the kids and that we feel what's going on. But realistically, if we're stretching them, it's only for a few minutes a day. If we're able to get these braces, these nighttime braces on the kids, they're getting a much longer stretch. And it's really, really important that we have these custom made for the kids, because if we're asking them to wear it for a long period of time, we want a good fit. We want a tight fit, and an off-the-shelf AFO or DAFO, dynamic AFO, An off-the-shelf one just will not do what it's supposed to do. It will not give a stretch and it won't be comfortable. So the ones that are specifically made for the kids tend to work a whole lot better. You can see a couple of two different ones here. One is a solid ankle, and the other one has a hinged ankle with straps for pulling tighter. This hinged ankle, the dynamic one with the straps, is really more appropriate for those younger kids that have more range of motion and have more flexibility within the feet, because you can you can use the straps to get dorsiflexion, get a little bit more of a stretch while they're sleeping. But these are two options that you can see. So that's the end of my presentation. This here is you have the our contact information, the Cure Duchenne physical therapy team, myself and Jennifer, our email address, as well as our Facebook information. Please feel free to reach out to us at any time. We want to try to be a resource. I think Cure Duchenne is doing fantastic work with providing education, both for therapists, doctors, also for parents, so you can use this information as you see fit. Thank you very much. Again, I really appreciate being part of the conference and allowing me to present, and hope you guys have a great day.